Hello everyone, and we've got another great case this week from Elsa. So this is the 4-year-old male neutered boxer with a 5-day history of an abnormal eye. So we'll have a look at the MRI and see what that showed. So this is the MRI, and for ocular and orbital disease, dorsal plane images are often very helpful. So if we have a look on the dorsal plane first, what we're looking for is obviously we're looking for is there any symmetry in the orbits, things which might result in abnormal ocular position or involve the nerves and muscles which supply the globe. So here, this is right, this is left. Initially, on kind of superficial glance, the orbits look fairly symmetrical. The variation in eye position is just due to general anaesthesia, so we can't really infer anything from that. So key questions we'd be thinking about in this case are, where do we think the neurolocalization is, particularly for ophthalmic disease and orbital disease. The localization of where we think the pathology is quite important, because if we have pathology involving the cranial nerves, this can be really subtle, and we need to tailor our MRI study to have high resolution sequences, often with fat suppression, to be able to visualize the pathology. So this is the transverse T2. So this is a boxer, and so we have some incidental findings here which are quite common in this breed. So partial absence of the septum pellucidum, resulting in a unicameral lateral ventricle, would be quite normal. So as we scroll through, what we can see is we have this abnormal, or this asymmetry in the middle cranial fossa. So we have a small nodule of tissue here, which lies just lateral to the pituitary gland on the right. So we'll have a look at that on the other sequences and see how this, whether this is genuine or not, and what it might refer to. So when we have subtle pathology or pathology which is very small, it's quite important that we cross-reference between different sequences and different imaging planes to confirm that the pathology is genuine. So here we have the transverse T2 flare, T1 pre and post contrast. And so what we can see on this particular MRI is that we have this area on the T2 in the middle cranial fossa, where we have this focal, small, relatively sharply marginated T2 hyperintensity. It's got a bit of a mass effect, so we can see it's displacing dorsally the adjacent thalamus. We can see it on the flare sequence, some suppression of signal, or certainly an area of low signal here, which might suggest that there's perhaps a degree of cyst formation associated with this lesion. Hard to see because it's so small. But we can confirm it on the T1, where the lesion is still visible, and on the post-contrast images. In this case, I think is particularly helpful, where we see this abnormal focal enhancement of this abnormal tissue, but also of the adjacent meninges. So this is quite a complex area to evaluate, and there's lots of vascular structures. So we have the cavernous sinuses, we have the arteries of the communicating branches, the circle of Willis in this area as well, and obviously there's a variety of cranial nerves run through the middle cranial fossa adjacent to the pituitary gland. So in this area here, this would be in the region of the ocular motor nerve. Given the history, this is something we'd want to be considering, but obviously we also have other cranial nerves which supply the extraocular muscles running through this region as well. So we'll have a look on in this particular case, we have a fat spread sequence, and that's very helpful. So here we have the T1 pre-contrast, the normal T1 post-contrast, and additionally we have a T1 post-contrast with fat suppression. So if we look at the bones of the calvarium, we can see the suppression of fat in the normal cancellous bone, and we can see that's very helpful, particularly when we're looking at pathology in the ventral aspect of the brain or cranial nerve disease. We can see it's much easier to evaluate what's going on when we null the signal from the fat. And here, this is a digital subtraction imaging. This can be very helpful when we're trying to pick up areas of subtle enhancement. So this is just a post-processing technique. So in this particular case, what we can see is the abnormal enhancement, and actually we see it much better here in the fat spread sequence. So it appears to be involving the region of the oculomotor nerve, which is here. But additionally, we have this focal area of meningeal enhancement adjacent to it. Going rostrally, we can see that actually this is the orbital fissures, and we can see that there's asymmetry in the enhancement of the orbital fissures. So we can see this abnormal structure here, which is enhancing, which we don't really see on the contralateral side. So obviously the oculomotor nerve runs through the orbital fissure, and so the pathology here appears to be involving the oculomotor nerve plus the adjacent perineural tissue and on meninges. So enhancement of nerves is abnormal, but a fairly non-specific finding. If we go further caudally, actually we can see here the trigeminal nerves. So it's normal for nerve ganglia to enhance. They're outside the blood-nerve barrier. So here we can see the ganglia of the trigeminal nerves enhancing, and this would be normal, but what we don't expect to see is actual enhancement of the nerves themselves. So one thing to look for when we have suspect peripheral nerve disease that's efferent to skeletal muscle is that commonly we'll see changes or signs of denervation, which can be quite helpful in confirming or suggesting the presence of peripheral nerve disease. And this is, in this particular case, we see evidence of denervation within some of the extraocular muscles. And so denervation in muscle causes the so-called muscle edema pattern. So what we expect to see is that we see diffuse T2 hyperintensity with diffuse contrast enhancement, and then usually a degree of atrophy in the subacute and more chronic cases. So the appearance will vary depending on the chronicity. In this particular case, we see signs of denervation. They're pretty subtle. So if we look in the dorsal plane images, we see, if we compare the affected side, the right and the left, we see this atrophy and subtle increase in signal within the medial rectus muscle here. If we compare it to the left side, and also if we look on the transverse plane, we can see here the subtle asymmetry in muscles. I think probably we see the difference better on the post-contrast images, whereby if we look at the degree of enhancement of the extraocular muscles, we see that on the right we see this relatively greater enhancement, and particularly on the subtraction. So here we have the typical appearance of denervation changes in skeletal muscle. So in conclusion, the MRI showed the presence of enlargement of the right oculomotor nerve in the middle cranial fossa, and extending into the orbital fissure. There was abnormal contrast enhancement of the right oculomotor nerve and the adjacent meninges or perineural tissues. And we saw some changes in the extraocular muscles, which were suggestive of denervation. There was no visible signs of extension of pathology into the brainstem or mesencephalon, and the rest of the brain was otherwise normal. Likewise, the rest of the cranial nerves appeared to be unaffected and were normal. So if we look at differentials, the primary differentials for me in this case would be idiopathic disease. We'd also need to consider, could this be some form of neuritis? Lymphoma often or can involve the cranial nerves, but typically will involve multiple cranial nerves. And so for me that will be less likely, but not totally excluded. And there was some meningeal involvement, but it appeared to me primarily to be nerve rather than primary meningeal disease. Obviously we see lots of pathology in the middle cranial fossa, which can involve the cranial nerves, so-called cavernous sinus syndrome, so there's lots of pathologies in that area. But in this particular case, it appeared very much confined to the oculomotor nerve itself. So hopefully you found that interesting, and we'll look forward to seeing the outcome of the case on Friday.